We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a GHD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. For a long time for various indications, but there are certain indications in which growth hormone has now been used extensively, and the responsiveness of growth hormone may be quite variable in that perspective. And if we see the classical indication is in the form of growth hormone deficiency, wherein it was used and it was found to have a good response. This looks like a busy slide, but what you need to focus on, that there are multiple indications in which growth hormone has been used, and you find a good enough response. I'll largely be focusing about 3 major indications, that is Turner syndrome and SGA, with a bit about Prader-Willi and idiopathic short stature. We had a debate also on idiopathic short stature. So the main thing to remember is that, of course, GHD, you will have very good response. You expect a gain of around 10 to 15 centimeters in the first year, and then 8 to 10 centimeters in the subsequent years. With Turner syndrome, the responsiveness is 1 to 1.5 centimeter per year gain in terms of final height. And when we talk about SGA, the gain will be somewhere around, again, 1.5 centimeter per
year. So this is something you need to really look at. So we'll talk briefly about Turner's, SGA, a brief word about Prader-Willi and ISS in that perspective. So when we talk about Turner syndrome, growth has multiple factorial effects which happen in the setting of Turner syndrome. One, of course, is the issue of the SHOX gene, which is the predominant determinant of growth in that perspective, causing intrinsic growth failure. So there is a component of skeletal dysplasia, which is there. There is also a long-term estrogen deficiency, which starts right from birth. So boys always have a lower level of estrogen than girls, even during the prepubertal age group. So whether this estrogen deficiency in Turner's will be responsible for growth is an issue, and people have used various therapies on that regards. There's also an issue of hypothyroidism, celiac disease, which can also happen in that regards. So what can we do? We can, of course, give a pharmacological therapy of growth hormone in this indication. And there have been certain studies about whether giving a low dose estrogen is going to help out. And to increase the duration, we talk about modulation. So one modulation you can give is to delay the start of estrogen in that regards to get a good outcome from that perspective. There's also a role of anabolic agent like anabolic steroid like oxandrolone, which can also be used. Now, this is the normal growth pattern in Turner syndrome. They are reasonably okay. They are on the shorter side at birth, but they are not really short. Till around 3 to 5 years, their growth falters. And most girls will be short by around 4 to 5 years of age. So if you want to target, the best time to target will be around 5 years to consider starting growth hormone in Turner syndrome. If you delay, they will keep on drifting from that. And their final height will be like 20 centimeters short as compared to the mid-parental expectation. So this is like 130 centimeters will be the upper limit in terms of classical Turners in Indian girls. That's what we can talk about. So now let's go one by one about the case scenario. 6-year-old girl with short stature, height is minus 1.6 SDS, FSH is marginally elevated. Now, FSH is not a good marker in prepubertal state, but if FSH at this stage also is high, that is a big pointer towards Turner syndrome. Of course, do a karyotype which showed an exokaryotype and was planned for GH. Now, what do we do in that perspective? So I'll base largely upon the Turner syndrome guidelines, which are there from the Cincinnati meeting. In that indication is not just short stature. Now, this girl is not short now, but she is destined to be short. So what they're talking about, not all people who are short you will start, you can start even earlier. So growth velocity less than 50th percentile, who is short or who have a high likelihood of being short would require growth hormone therapy. There is no need for growth hormone or IGF testing in that regards. Now, if we go here, the screening workup was normal. Now, one message is always look for celiac and thyroid disorder before you really start about growth hormone in this perspective. The girl was started on 25 microgram per kg per day. Do you agree with this dose? This is a homeopathic dose as far as Turner syndrome is concerned. You don't expect any increase in growth velocity despite a good adherence. We should right away start with a high dose. So what do the guidelines suggest? The minimum dose is 45 microgram per kg per day. And I've seen this in many prescriptions that a lower dose is given. Anyway, the response is not going to be as good as GHD. So if you give a lower dose, you will have hardly any response happening. So this is the minimum dose. And in obese girls, often it is preferable to use a body surface area based dosing because then you will be giving a lower dose and you may cut in terms of cost in that perspective in that regards. Now, people have done studies and seen that in older girls, it may be beneficial to use a body surface area-based dosing, which will give you a more efficacious plan. Now, on follow-up, her dose was increased to 55 microgram per kg per day, and she started developing headache and vomiting. Now, we say growth hormone is extremely safe because we're talking about usually growth hormone deficiency. And you are giving a physiological replacement. Here, you are giving a pharmacological therapy. At a high dose, you can expect more side effects. So side effects are more common in Turner syndrome. Be aware. And IGF-1 was done, which was plus 3.2 standard deviation score for age and gender. Now, the target or the upper limit of IGF-1 in GHD on treatment is plus 2. In Turner, you can keep it up to plus 3, but not beyond plus 3 because then you need to really worry about. And we often see more acromegaloid features like increase in feet size and other parameters may happen in that regard. So adverse effects include edema, raised intracranial pressure, unmasking of hypothyroidism, slip capital femoral epiphysis, glucose intolerance, and scoliosis, and they are much more common compared to GHD. But still, the prevalence is not extremely high. I'm mainly worried about scoliosis. Many of these girls may have a scoliosis to begin with. So you need to be very, very careful in those girls about how they are progressing in that regards. And if you have a girl who suddenly was normal and suddenly complains of a knee pain, hip pain, difficulty in walking, that is the first sign of slip capital femoral epiphysis in this regards. As I said, you may have an increase in hand size. Nevi is common in Turner syndrome and they may go up. I have seen hemangiomas go up, so be cautious about all those things which may happen. Rare risk of pancreatitis, but there is no effect as far as the cardiac aorta or other parameters are concerned, which is a major cause of concern in Turner syndrome. And importantly, there is an increase in lean mass. You don't have an increase in adiposity in that regards. So the target IGF should be below +3 SDS is what the recommendations are. So we reduced the dose to 45. There was improvement in symptoms, and IGF-1 now became 1.5 SDS, and now she was advised low dose estradiol. Now this is a girl which is very young. And some people we discuss now is that if your estrogen level is low, you may benefit from a estradiol. So what they're trying to do is ultra low dose estradiol. Is there a evidence for the ultra low dose estradiol? So this was the only study which was published in NEJM, a big NIH randomized trial in which they started at a very, very low dose of ethinyl estradiol, which was in terms of injection. And what they found was that the initial phase, there was a benefit. But in terms of final height, there was no benefit. So giving an ultra low dose estrogen in Turner syndrome girls is not recommended. So I think this is something which I will summarize based upon that. Now we go to another case. This is a 1-year-old girl with lymphedema. Now this is an early diagnosis. Unfortunately, we have usually a late diagnosis. What do you think is the average age of Turner diagnosis in our clinics? Anybody? 9, 10 is too early. Most of them come to us with delayed puberty. So if you talk about actual, it will be like 13, 14. If you saw in onsite, a lot of them come. So there'll be some who will come with short stature, but most will come with delayed puberty. In the US, till 5 years ago, it was 9 years. So the average age of diagnosis Turner's even there was 9 years. So we have even later presentation. But sometimes, like this girl comes to you at 1 year with lymphedema, and somebody has really thought that this could be something else. Her height is not short. She has got classical Turner syndrome. Now, the question is, do we treat now? And this was a big debate whether toddlers with Turner syndrome should be treated with growth hormone or not. And this study, initial data, now this is again interesting. So estrogen data, remember, in the initial phase, good response, but final height, no response. So the same thing probably came up with a toddler study also, which showed that there was a very, very good response if you started treatment early, which is expected. But at the end, the benefit is very, very minimal. So on final height, there was no significant difference between those who were treated from toddler or those who were treated from 5 years. You have given 3 extra years of growth hormone. Remember, this is a lot of injections, a lot of cost and other adverse effects, and not much benefit. So even if you gain a couple of centimeters, people really say that before, around 5 years before, it is not going to benefit much. So usually, that's why the Cincinnati guidelines say that you are either short or you have a high probability of being short. At 0.6 SDS at 1 year, it's better to observe and wait and watch in that regard. So NAH, the near adult height, was not significantly different in that regard. So they are saying 6 years of age is basically a good enough time. Don't start right away. But we need to pull down the time of diagnosis from 13, 14 to 6, because that's a major problem that we see. Now, this is what we usually see. A 13-year-old girl with delayed puberty, reasonably short, no breast, no pubic hair, classical Turners. Now, what do we do? Now, if you go by the guidelines, they say we should give growth hormone at least for 4 years before pubertal onset to achieve a reasonable amount of outcome. But this at 13 years, are you going to defer the pubertal induction till 17 years is going to be a big question. So what are the options you can give? One is delaying pubertal induction, other is oxandrolone, which is a non-aromatizable androgen. It is not going to increase the bone age, but it is ultimately an androgen. So it may cause some clitoromegaly. It may cause some features of hirsutism, which you need to watch for. So there are studies which have shown that if you give oxandrolone, you may not need to defer pubertal induction. This is the UK study, but there is very limited availability of oxandrolone, so we are not using it, plus the possible side effects. So androgenic side effects is going to limit that. So Turner syndrome, just to summarize, better would be to pick up early. 5 to 6 years is good enough. Don't wait beyond 5 years, because if you start at 5, the weight may be 20 kgs. If you start at 12, the weight will be 40 kgs. The cost will anyway be double. So this is something, treat early will be better. Don't expect a dramatic response. 1.5 centimeters per treatment year gain in final height is what you expect. So you treat for 5 years, gain around 7.58 centimeters is what you expect. The second group is the SGA, and in SGA we know that they have a high growth hormone in the fetal period, and they also have a postnatal growth hormone resistance. They also tend to have an early puberty. So SGA are short at birth. Those who are not catching up will not have growth, and then they will have early puberty. So this is something which you have to be really worried about. Plus there are syndromic associations which are also there in that regards. So you have a 5-year-old boy whose birth weight is 2.1 kg. You can see here, the child is short, the development and other parameters are reasonably normal. So what do you do in terms of the plan of therapy? Now, 85% SGAs will catch up by 2 years or maximum by 4 years. So the recommendations which Dr. Hemchand was talking about suggest that if a child is below minus 2.5 SDS by 2 years and minus 2 SDS by 4 years, that is the time they require evaluation. Now, that doesn't mean that you treat everybody, you at least evaluate in that perspective. This is the recommendation. So minus 2.5 at 2 and minus 2 at around 3 to 4 years of age. The 4-year-old girl, birth weight 2 kgs, normal development, she's short, she has dysmorphism and low set ears. What do you do? Now you will say, okay, this is SGA, not catching up. I'll screen for common conditions, correct nutrition, start growth hormone. But remember, there are certain conditions in which growth hormone is contraindicated. And if you are not clear about that syndrome, the recommendations are that you should consider for those genetic causes and genetic screening before giving growth hormone. And of course, when you're giving such an expensive treatment, you don't want to do any harm. So better is to really screen for high predisposition conditions like chromosomal breakage disorders. So do a targeted panel. You may find something which is a contraindication to GH. So this is the new message from the guidelines, that before starting growth hormone, if you feel that there are dysmorphic features, better to get a NGS before starting treatment. And probably we are following this up and we are picking up some strange scenarios, which may not be a contraindication, but at least you know what the problem is. So this is an important thing to remember. Now, a 7-year-old boy who is SGA has normal faces and development, short stature, and what we are seeing here on growth hormone treatment should be given or not, or what sort of growth hormone should be given in that regard. So as we said, 4 years probably the reasonable time to wait. Beyond 4 years, not much waiting is going to be there. 33 to 67 microgram per kg per day is the appropriate dose. As far as growth hormone is concerned, you do not need to do a growth hormone IGF evaluation. But sometimes if you get a very, very low growth hormone, that may guide your dose. So if your growth hormone is low, lower dose will work. Growth hormone is high, you need a higher dose. So it's not routine recommendations, but sometimes we will be doing that. There are different guidelines. Generally, most countries wait till around 4, except the US. And the US are more liberal. They are starting very, very early at a high dose of growth hormone. But we cannot follow the same guidelines as Neha was talking about, that we have to look into our own country. So not everybody who is SGA not catching up. That will be like crores of people who will require growth hormone. But we should be focused. So somebody who's extremely short, we should give them an option in terms of severity. Now, what happens in terms of response? So just to summarize, we expect 1 to 1.5 centimeter per treatment year increase in growth hormone treatment. That's it. So don't expect a 25 centimeters increase. If you treat for 6 years, maybe 9 centimeters extra. If he was landing at around 150, he'll become 159. Don't expect that he'll go to 170. That is something which is important to understand. And the dose, as I said, is on the higher side. Now, on follow-up, growth hormone was increased. There is a rapid weight gain and there are metabolic concerns. Now, what is going to happen in terms of adverse effects? Again, adverse effects are more than GHD, but they are less than Turner syndrome. So if you look at the figures for benign intracranial hypertension, or if you look at subcapital pulmonary, that was 1 in 400. This is 1 in 1600 treatment years, and other parameters are rare. Now, many people worry about glucose intolerance, but remember, SGA who gain too much weight will be more likely to develop metabolic syndromes. SGA who are not catching up are not at that much risk. So this is a different ball game we are talking about. The two trajectories for SGA, so to speak, in that perspective. So 11-year-old boy with birth weight of 2.4 kg with growth concern, extremely short, as you can see here, but has already entered into puberty. So this is something of a concern. Now, what do we do? Now, we know that the SGA will have earlier puberty and a more rapid progression of puberty. So when I'll talk about precocious puberty, I'll say that if you have a precocious puberty in a SGA girl, always treat. While SGA, non-SGA obese girl, you can maybe wait and watch. So this is something which is there. Bone age is already advanced and we need to really work out. So it's been shown that you may have a role of giving GnRH analog in this particular indication, and Hemchand also was talking about. And the guidelines say that if you have a predicted adult height below minus 2.5 standard deviation score at onset of puberty. So remember these figures, minus 2.5 at 2 years for evaluation and minus 2.5 predicted adult height at around the onset of puberty. You can give GnRH analog along with growth hormone to delay. So there is a clear-cut guideline which is now coming up in that regards. So we've discussed about the two common ones. What about Prader-Willi? Prader-Willi, what you need to understand that this is mainly for body composition, reducing body fat and decreasing adiposity. You need to have a genetically confirmed diagnosis. GH testing is not required, and you need to be very cautious with growth hormone because they have a tendency of obstructive sleep apnea. You should evaluate, treat that, and then only you need to go ahead with that. Start with a low dose and use a body surface area based dosing because you will be giving too much of a dose if you give a per kg dose in this regards. Very importantly, they have a severe sleep apnea, diabetes, or severe obesity. In that regards, you may have to avoid this. Monitor them for IGF-1 level, which should be upper half of normal. Do a sleep study in that regards. What about idiopathic short stature? Dr. Vijay had a very wonderful debate with Vibha. So it's already been covered. The key message is the indications are that height less than minus 2.25 STS after 5 years. So does that mean 1% of our population should give growth hormone? I think the answer is no. Somebody who's very short, you will treat, but maybe marginal cases not required. You need to evaluate for all known cause. Dose required is high. There may be some increase in height by around 3 to 5 centimeters, but at an astronomical cost. So in the US data, it shows $10,000 per centimeter gain in ISS. What I'm trying to say is that ISS basically, some people may have mild GHD, some people may have mild GH insensitivity. So you can't label every ISS as the same. Give them a trial for 6 months, see how much they are growing. If their growth velocity has doubled, maybe you continue. If not, you stop it. So if somebody is below minus 3 SDS, this would be my suggestion or approach that I follow. From that, minus 2.25 will be too much. That's like 1 percentile. Minus 3 SDS will be 0.199. So that will be like 10 times less. At least the burden will be less in that regard. So give a trial for 6 months. And if the height SDS is not increasing by more than 0.15 in the overall period, stop the treatment in that regards. There are also studies about the use of aromatase inhibitors, growth hormone in pubertal children. This has already been discussed. So this is some strategy which can be considered. So just to summarize, there is no role of growth hormone IGF-1 testing in non-GHD conditions. Pharmacological doses are required. You tolerate higher IGF levels. Response is not as excellent as GHD, and pubertal modulation becomes